Good afternoon, everyone. My name is Dr. Olivia Van Gerwen, and I am an infectious diseases doctor at the University of Alabama at Birmingham. I just finished my fellowship in infectious diseases and am about to begin a faculty position this fall. And I'm also a postdoctoral fellow for a T32 at our institution that focuses on health outcomes and effectiveness research. So today I'll be talking to you about our group's meta-analysis that we performed looking at Trichomonas vaginalis and adverse perinatal outcomes. I have no financial disclosures, and as I mentioned, my work is supported by a T32 training grant from the Agency of Healthcare Research and Quality. To begin, we must first understand the epidemiology of Trichomonas vaginalis globally, and then on a more local and national United States scale. So the WHO in 2016 estimated that about 156 million incident cases occurred among women and men in the reproductive age range. And the prevalence in that study was found to be about 5.3% of women. Men, as you can see, experienced a much lower prevalence of the infection. The NHANES data from 2013 to 2014 captured men and women in the United States, and through their testing, which used NAT, nucleic acid amplification testing, they found that 1.8% of women in their reproductive years were experiencing Trichomonas vaginalis. And then finally, just from our local health department in Jefferson County, Alabama, we did a study back in 2014 that estimated that about 27% of the women presenting to our sexual health clinic and had NAT testing performed had a prevalent Trichomonas vaginalis infection. So this is definitely something that impacts women of reproductive age at high rates. Now, pregnant women, less is known about the epidemiology of that population. There is a lot of variation in different parts of the world as far as how common this infection is, but we don't have a lot of good, solid data to give us an idea of how common it is in the United States in particular. We do know that some observational studies in Africa and Latin America have reported a prevalence of as high as 24.6% among pregnant women. And then the WHO has estimated that about 25 million pregnant women annually are affected by trichomonas. And in the United States, as I mentioned, there's limited data, but there's another interesting study that has found that there are high rates of repeat infection among pregnant women. Up to 44% of women who are treated once they're found to have trichomonas during their pregnancy are tested and despite treatment still positive. So there's a lot of questions about whether or not they're getting reinfected or if treatment needs to be adjusted in the setting of pregnancy. Now, it is important to note that treatment with metronidazole, which is the preferred treatment of Trichomonas vaginalis, has been found in multiple studies to be very low risk at all stages of pregnancy. So while it's a common infection, there is a safe and effective treatment option. Now, why do we care about this? So there are a lot of consequences associated with Trichomonas infection that many of you probably are aware of, but I'd like to focus on some of the ones that affect pregnant women and therefore lead to perinatal outcomes that may be detrimental to either the mother or the infant or both. So there are some data to suggest that preterm labor and thus preterm delivery are more common in women who have Trichomonas infection. And then there are also less data to suggest that T. vaginalis infection, like with a lot of other STIs, is associated with the premature rupture of membranes, low birth weight, and even possibly infant mortality, though that is a highly complex outcome and could be affected by any of these other perinatal outcomes. But it certainly is something that is of consequence in pregnant women and thus is worth thinking about. So back in 2014, Silver and colleagues published a systematic review and meta-analysis looking at trichomonas and its association with perinatal morbidity. And the 4 outcomes they looked at were preterm delivery, premature rupture of membranes, infant mortality, and then low birth weight, as well as small for gestational age infants. So when they, back in 2014, did a systematic review, found that there were 11 studies that looked to find an association between one or many of these outcomes. And what they found was preterm delivery was about 42% more likely in women with T. vaginalis than uninfected women. And this was with a I-squared ratio of 62.7%. So it was certainly a pretty homogeneous group of studies that they looked at. They also aimed to find an association between premature rupture of membranes and, preterm rupture of membranes, as well as premature preterm rupture of membranes. So the PROM, or premature PROM, they only found 2 studies that they were able to run any kind of meta-analysis techniques on. And they did find an association, but because there were only 2 studies, it's very difficult to extrapolate whether or not there's a true connection. And the same was true when they looked at low birth weight and small for gestational age. They were only able to do an analysis for the small for gestational age outcome. And again, only 2 studies were looked at in their analysis. Thus, it's difficult to know if there was a true association. So the limitations of this study were that very few studies reported on all of these outcomes. So, there were not a whole lot of studies to compare in the meta-analysis. And the only clear association that they found was the preterm delivery and T. vaginalis connection. Because they did find associations between PROM and small for gestational age, but the small number of studies makes it very difficult to know for sure how these are connected. Now, they also included infant mortality as an outcome, but because of the marked heterogeneity among those studies, they were unable to perform any analysis to look for an association. And finally, the current standard of care as far as testing and screening for trichomonas is to use the nucleic acid amplification testing methods. And these were not really widely available at the time of many of these studies being conducted. So older and less sensitive testing methods were used for many of these studies, such as wet mount and culture of trichomonas. Thus, in more recent studies, in more current studies in the last few years, it's possible that higher detection of trichomonas in pregnant women may be seen. So we as a group wanted to basically provide an updated systematic review and meta-analysis looking at these topics. And because we had noted that there has been an increase in the literature looking at these associations between perinatal morbidity and T. vaginalis, we wanted to both look at the studies that the Silver paper looked at, and then also any papers that have been published since that time. So we examined the association between T. vaginalis and pregnant women for 4 adverse birth outcomes: preterm delivery, premature rupture of membranes, which includes preterm premature rupture of membranes. Infant mortality we initially looked for, but unfortunately we're unable to run any analysis on this, so we won't mention it anymore. And then low birth weight. To be included in our study, papers had to be written in the English language and be original research. They must look at one of the 4 mentioned adverse birth outcomes, and then the laboratory confirmation of a T. vaginalis diagnosis was required. So there had to be a confirmed wet mount microscopy, T. vaginalis culture, NAT, or rapid test result confirming infection. We excluded studies that were reporting a diagnosis based on self-report or billing code if there was no laboratory confirmation as well. Then we also excluded studies that provided a secondary analysis on data that was already included in our study as to not repeat studies in our analysis. And then finally, we didn't include anything like a case report or systematic review or case series. This diagram shows the screening process that we used in our systematic review. So we reviewed articles in PubMed, Embase, and clinicaltrials.gov. And after reviewing the titles and abstracts and then full text and ones that were relevant to our study, we excluded 35 articles from full text review from a total of 53 that we reviewed for the reasons that you can see here. And after that process, we included 18 studies in our meta-analysis. So onto our results. We performed the random effects analysis on 3 of the outcomes, as I mentioned: preterm delivery, premature rupture of membranes, and low birth weight. So here you can see the various studies that we included that looked at preterm delivery. There were 10 of them, and we found that among pregnant women with T. vaginalis, the odds of preterm delivery were 1.27 times that of pregnant women without Trichomonas vaginalis. This is in keeping with what was found in the Silver paper, but there were more studies that were able to contribute to this analysis. Next, we looked at premature rupture of membranes, and there were 7 studies that we were able to run our analysis on. And after analyzing these, we found that among pregnant women with trichomonas, the odds of PROM were 1.9 times higher than that of pregnant women without TB. Now, this was new. This was not something that was found in the Silver paper. And I will note that clinically, premature preterm rupture of membranes is probably more significant than just premature rupture of membranes, the water breaking before 37 weeks, before the onset of labor. But some of these studies did include the PROM outcome as well. Next, we looked at low birth weight, and we were able to look at 6 studies in this analysis and found that women who had TB had an odds 2.2 times higher than pregnant women without TB to have a low birth weight infant. Now, the I-squared was quite high in this particular analysis, so the heterogeneity of the studies included was a bit higher than the previous one. So that's just something to keep in mind. But again, this is a new finding. There were several studies looking at this outcome, and there was a significantly higher odds of women having this adverse birth outcome if they did have trichomonas. So to kind of parse through these results, a couple of comparisons between the 2 studies. One benefit of our study is since we have conducted this with a lot more studies that were focusing on this infection with these outcomes, we were able to include 18 studies compared to Silver's 11, and 8 of these studies were published since the publication of Silver. The other thing that is important, yet not as profound as we expected to see, there were several studies that we included in our analysis that used NAT or OSM testing, whereas Silver had no studies that included that. And then finally, we found new significant associations between PROM and low birth weight. As I mentioned earlier, Silver did look at PPROM and small for gestational age, but this was only across 2 studies for each outcome, whereas all of ours that we found significant associations for had at least 6 studies to have the analysis run off of. So why does this happen? What is the cause of these adverse birth outcomes in relation to trichomonas? So there's not a lot that is well understood about this, but several theories have been proposed in the literature. One such theory is that there are increased levels of cervical IL-8 and cervical defensins that are related to the maternal innate immune response, and those activate neutrophils and cause cervical ripening and dilatation, which can obviously, as the cervix is opening, lead to delivery and rupture of membranes earlier than is expected. So these cytokines may be related to the pathophysiology of this phenomenon. As far as low birth weight and small for gestational age, There is a thought that the inflammation in the uterus caused by T. vaginalis may somehow impact the circulation of the placenta, leading to less blood flow to the fetus and thus a lower birth weight at the end. And I'll go back to this slide and mention, it's very difficult to say that these adverse birth outcomes are solely related to Trichomonas vaginalis. There are obviously other factors that impact these outcomes happening, such as sociodemographic factors like smoking, obesity, other medical conditions, and then also co-infection with other STIs and HIV could possibly play a role. But as far as the pathophysiology and pathogenesis of Trichomonas implicated in these outcomes, these are some of the theories. So some of the limitations for our study were that we saw fewer studies utilizing advanced diagnostics than we expected to. I think, the future will show us, hopefully, that more people will be using these advanced diagnostics, and hopefully we can have a better idea of of true prevalence of this infection, and then possibly be able to draw more conclusions about their impact on perinatal morbidity. The other thing that I mentioned already was that there was significant heterogeneity among the studies that reported on low birth weight. Additionally, as I mentioned, confounding factors can also lead to adverse birth outcomes. This does not all occur in a vacuum of Trichomonas. So analyzing this data is difficult in terms of accounting for all of that confounding. And finally, as I mentioned, the role of T. vaginalis in concert with other STIs, including bacterial vaginosis, which is a frequent co-infection of Trichomonas, it's difficult to know how much of a role each of these factors plays. Some of the studies that were included did, within their analysis, adjust for co-infection with either STIs or BV, but there were only a handful of them that did so, and some of the methods were kind of heterogeneous in that fashion. So again, it's kind of difficult to know how much Trichomonas is playing a role in and of itself. In conclusion, I think it's important to draw from this that we have in Trichomonas vaginalis a common curable STI that is often asymptomatic and diagnosed commonly in pregnancy, and can be a major source of reproductive morbidity because it can lead to preterm delivery, preterm rupture of membranes, and then premature rupture of membranes, and then also low birth weight. And because of this, I think it's important that we consider rigorous studies to determine what impact screening for T. vaginalis universally, and thus treating the infection during pregnancy, looking at what role that may have in reducing the incidence of adverse birth outcomes. And with that, next steps in this study would be to have trials clarifying the link between these two parties, the infection of T. vaginalis and the adverse birth outcomes we've mentioned. And then also, since little is known about the pathogenesis, studies that would assess the role of these cytokines that I've mentioned in the pathogenesis of T. vaginalis in pregnant women would be very interesting. With that, I will acknowledge people who've helped me with this project. My team at UAB includes a lot of people, including my co-authors, and then my mentor, Dr. Christina Musney, as well as our colleagues at Tulane who helped us with most of the epidemiologic analysis of this project, Drs. Kissinger and Bukins, as well as Megan Clare, Craig Kuhn, and Austin Jones. So with that, I'm happy to answer any questions within this broadcast, but I've also put my email address on here if anyone would like to email me with questions or comments regarding this study. Thank you.
Hello, my name is Jenna Sutzker. I'm an epidemiologist at the New York City Department of Health and Mental Hygiene in the Bureau of Sexually Transmitted Infections. And today I'm going to be speaking with you about an analysis of the burden of infant deaths due to herpes simplex virus. Neonatal herpes occurs when a pregnant person with herpes simplex virus transmits this infection to a neonate. Transmission happens most commonly during delivery and is much more likely when the pregnant person has a primary herpes infection when compared to a prevalent recurrent infection. Also of note, most pregnant people that deliver an infant with herpes infection show no evidence of infection at the time of delivery. Herpes infection in a neonate can result in a number of adverse outcomes, including permanent brain damage and early infant death. There have been advancements in the diagnosis and treatment for herpes infection, including the application of PCR tests to cerebrospinal fluid specimens and the use of high-dose acyclovir. Despite this progress, however, the case fatality rate for neonatal herpes remains as high as 30% for disseminated infections. Despite the severity of herpes infection, this condition is not a nationally notifiable condition, and consequently, understanding the burden has been challenging. Estimates of neonatal herpes incidence vary widely in the U.S. and depend on several factors, such as geographic region, study population, data source, and the prevalence of genital herpes infection in adults of childbearing age. Furthermore, long-term trends may be impacted by the broader availability of PCR testing across time. Estimates of death rates are limited even further, and the authors are aware of 3 U.S. studies that characterize herpes-related infant mortality. These investigations all use disease codes on death certificates as a methodology and arrived at a similar estimate of around 0.8 herpes-related deaths per 100,000 live births. The Florida study calculated death rates using surveillance data in addition to vital records, which resulted in a broader range of estimates. The lack of recent and national data assessing the burden of neonatal herpes remains a large gap in the literature that this investigation aims to address. Our primary objective was to characterize trends in herpes-related infant deaths on a national level across a wide time frame. In addition to quantifying herpes-related mortality, this analysis will also provide insights into disease burden trends given the absence of U.S. incidence data. Secondarily, we sought to compare the number of herpes-related infant deaths to the number of deaths from congenital syphilis and HIV. Prevention of both these perinatal infections is widely recognized to be a top priority in the field, and so we were interested in examining how deaths related to herpes compared to deaths related to these sentinel infections. Our data source was the National Center for Health Statistics period-linked birth infant death data files. These files are released publicly on an annual basis and include all infant deaths that occurred in a specific year linked to their corresponding birth certificates. We downloaded all data files that had been published at the time of this analysis, which included infants who died between 1995 and 2017. From these files, we identified all infants who had a disease code for herpes, syphilis, or HIV listed on the death certificate. And this table will show how we classified infant deaths using ICD codes. For congenital syphilis and HIV, we included all infants with an ICD code for syphilis or HIV on the death certificate, under the assumption that infants who died within a year had contracted the infection perinatally. For herpes, we applied different criteria based on infant age at the time of death, such that infants who died at 42 days or older needed to have a code indicating perinatal infection specifically. And we did this to increase the likelihood that infant deaths that we were capturing were related to neonatal herpes and not to an infection that was acquired after the neonatal period. Lastly, for each infant death that met the inclusion criteria, we abstracted infant sex, year of death, age at death, and paternal race ethnicity. Nationally, from 1995 to 2017, we identified 1,579 infant deaths that were related to the 3 perinatal infections of interest, including around 1,200 deaths related to herpes, which made up around 80% of all infant deaths, 85 deaths related to congenital syphilis, which represented about 5% of all deaths, and 232 deaths related to HIV, around 15% of all infant deaths. It is important to note here that this data set only includes infants that were born alive and then died. There are not stillbirths, and this is particularly impactful for the number of deaths related to syphilis. No infant had codes for more than one infection listed on the death certificate. The next 3 slides are specific to each infection and show the number of infant deaths that we identified by the year of death. The axes will be the same on each of these graphs to help visually compare frequencies across the infections. This first slide shows the number of infant deaths related to herpes, and you can see this increase from 32 deaths in 1995 to 68 in 2017, with a median of 54 deaths per year. This graph shows the number of infant deaths related to congenital syphilis, and you see a median of 3 deaths per year across the time frame, with elevated frequencies in 1995 to 1996 and 2017. Even without stillbirths, these findings still follow national trends showing decreasing early infant deaths related to congenital syphilis in the 1990s and early 2000s, and then the resurgence of congenital syphilis and its adverse sequelae in the past 5 years. This final graph shows the number of infant deaths related to HIV, and you see this steady decline from 63 deaths in 1995 to 0 deaths in the past 2 years, 2016 and 17, with a median of 4 deaths per year. This also appears consistent with national trends, which highlight decreases in perinatal HIV infections and deaths starting around the mid-1990s, which are related to highly active antiretroviral therapy and national efforts to prevent mother-to-child HIV transmission. The last 2 results slide focus on infants with a death related to herpes, and this table displays the infant sex and paternal race ethnicity. A slightly higher proportion of infants with a herpes-related death were male, 52%, and the majority of these infants were born to a white parent, 54%. This graph shows the age at death among infants with a herpes-related death, grouped into 5-day intervals. You can see that most infant deaths occurred in the first weeks following birth, and nearly all deaths, 98%, happened within 42 days of birth. Before concluding, there are a few limitations to address. First, we use death certificates for this analysis, and this administrative data source has several shortcomings. Death certificates lack information on important clinical characteristics, including the infecting viral type. There may also be misclassification in the assignment and recording of ICD codes. Second, these death files do not include stillbirths, so this is an incomplete picture of all mortality related to these perinatal infections. This is especially true for congenital syphilis, in which most deaths are stillbirths versus infants who are born alive and then died. In terms of major conclusions, infant deaths from herpes infection appear to be increasing in the US. This trend aligns with the 2 local studies of neonatal herpes mortality over time, which found stable and/or increasing rates starting in the early 2000s. There are a number of hypothesized reasons for this trend, and I'll highlight a few here. The first is that there's been decreasing prevalence of HSV-1 infection among adolescents, which may put people at childbearing age at a greater risk for acquisition of HSV during pregnancy. And as mentioned in the background, a primary HSV infection increases the risk for transmission to a neonate. This trend may also be related to increasing use of PCR tests for herpes diagnosis, which likely improves the detection of herpes in infants, both when they're alive and also during autopsy. A second major conclusion is that infant deaths related to herpes greatly outnumber those caused by HIV and congenital syphilis, excluding stillbirths in recent years. And this is an important finding because HIV and congenital syphilis are infections that receive a substantial amount of resources and attention. And so these findings really underscore the need for elevating the importance of HSV infection in infants. And some important next steps include an effective herpes vaccine, a rapid point-of-care test that enables identification of infants exposed to herpes at delivery, and increased public health attention and advocacy. Thank you so much for your time and attention. Here's a picture of me doing my favorite activity during our stay-at-home time, which are puzzles, and also my contact information for you to reach out if you have any questions. And I also wanted to acknowledge my co-author, Julie Schillinger.
Hello, I'm Preeti Patella. I'm with the New York City Department of Health and Mental Hygiene, Bureau of Sexually Transmitted Infections. I'll be presenting on chlamydia and gonorrhea infections among women receiving universal 3-site screening in New York City sexual health clinics. These are data that can be used to inform extragenital screening strategies. While female urogenital infections can lead to serious sequelae, such as pelvic inflammatory disease, ectopic pregnancy, and infertility, adverse outcomes associated with extragenital chlamydia and gonorrhea in women are rare. There may, however, be population-level benefits to screening extragenital sites. Screening and appropriately treating chlamydia and gonorrhea infections that are often asymptomatic in anatomic sites such as the rectum and pharynx could decrease ongoing transmission and possibly reduce population-level prevalence. Additionally, the pharynx may be important in the development of antibiotic-resistant gonorrhea, and so screening the oropharynx and appropriately treating those infections could help decrease gonorrhea transmission through oral sex. Reported anal sex is fairly common among women, with recent nationally representative surveys, such as the National Survey of Family Growth, finding that between 30 and 40% of women report having engaged in anal sex. Condom use during anal sex is uncommon. We have local survey data that show a decreasing trend in condom use with anal sex from 2015 to 2017, with 1/4 of surveyed women reporting its use. While most rectal STIs are believed to be associated with anorectal sexual exposure, a handful of studies have reported on rectal chlamydia and gonorrhea infections among women who did not report engaging in anal sex. Currently, there are no specific US guidelines for extragenital chlamydia and gonorrhea screening for women. Rather than screening, testing does occur most often in sexual health clinic settings and among patients who report having anorectal or oropharyngeal signs or symptoms or engaging in anal or oral sex. We conducted a 3-site screening project to quantify female extragenital chlamydia and gonorrhea infections that would be missed by routine testing practices and which can be used to inform optimal control strategies. Our project took place in 3 of 8 New York City sexual health clinics. These are the 3 with the largest numbers of female patients who received clinician evaluations during which sexual exposure and symptom history are ascertained and extragenital swabs are collected for testing. The project took place over 5 months, during which urogenital and extragenital specimens were collected for chlamydia and gonorrhea nucleic acid amplification tests. And 3-site screening was offered to all female patients irrespective of their symptoms and sexual practices, which is a departure from usual protocol that entailed testing women with exposures or signs or symptoms. We used clinic electronic medical records to examine positivity among screening encounters. For patients with multiple visits within 7 days of each other and no evidence of intervening treatment, we collapsed those visits to represent single screening encounters. And then among the unique screening encounters, we assessed anatomic site-specific positivity, the proportions of infections that would be missed without 3-site screening, and the association between receptive anal sex and rectal chlamydia infection. We had 2,309 screening encounters among 2,057 female patients. Virtually all included urogenital gnat, about 3/4 included rectal gnat, and 89% included pharyngeal gnat. For patients with multiple encounters, the median time between encounters was 51 days. Here we have characteristics of our patient population included in this project. 16% were under the age of 20. About 1/3 were aged 30 or over. 84% belonged to minority race and ethnicity groups. 1% of patients were living with HIV. And small proportions, 6% and 3%, were identified as contacts to chlamydia or gonorrhea, respectively. Looking now at some sexual behaviors and signs and symptoms. Behaviors were what were reported by the patient for the 3 months prior to clinic visit. Signs and symptoms were ascertained by clinicians on day of visit. 2/3 of patients reported no partners in the previous 3 months or a single partner during that time frame. 11% had receptive anal sex, 68% receptive oral sex, and almost all, 96%, had engaged in vaginal sex in the previous 3 months. An exceedingly low proportion, 2%, had rectal signs or symptoms, either by chief complaint or on physical exam. 2% had oral signs or symptoms, and 76% had vaginal or endocervical discharge. Looking now at anatomic site-specific chlamydia positivity by reported sexual exposure. This table shows the number tested, number positive, and percent positive for urogenital chlamydia, rectal chlamydia, and pharyngeal chlamydia. The percent positive for urogenital chlamydia, 8.9%, was identical to the percent positive for rectal chlamydia. As expected, we had low positivity for pharyngeal chlamydia at 2.1%. I'll draw your attention to rectal chlamydia positivity stratified by report of receptive anal sex. Among women who reported anal sex in the previous 3 months, positivity was 5.8%, compared to the positivity we saw among women who did not report receptive anal sex, which was 9.4%. This difference, however, was not statistically significantly different. Of note, of the 158 rectal chlamydia infections, 144 or 91% were among women who did not report anal sex in the previous 3 months. Now going to anatomic site-specific gonorrhea positivity, and the same sort of data that's showing that positivity was low between 2 and 3% for urogenital, rectal, and pharyngeal sites. 1,739 of 2,309, or 75% of encounters, included screening at all 3 anatomic sites. It was a total of 324 chlamydia infections detected at 184, or 10.6% of visits. At one-third of these infections were single-site infections. There were 120 multiple site infections that included 117 rectal and 26 pharyngeal infections. We had 125 gonorrhea infections detected at 62, or 3.6% of 3-site screening visits. Similarly, 1/3 of the infections were single-site infections. 41 multiple site infections included 33 rectal and 31 pharyngeal infections. We looked at the proportion of chlamydia and gonorrhea infections that would be missed by different screening practices. Screening only at the oropharynx misses the highest proportion of chlamydia and gonorrhea infections, 90% of chlamydia and about 70% of gonorrhea. Urogenital only screening, which is what is most routinely done, would have missed 56% of chlamydia and 61% of gonorrhea infections. And of those 182 missed chlamydia infections, 81% would have been rectal chlamydia. Finally, we looked at factors associated with rectal chlamydia. Our main exposure of interest was receptive anal sex, and we examined the following factors as confounders in bivariate analyses. In our final multivariable model, we included 4 variables: receptive anal sex, age, number of partners, and contact to a confirmed chlamydia case. In the adjusted model, there was no association between receptive anal sex and rectal chlamydia infection. We did see an association with age, with patients who were under the age of 25 having a higher odds of a rectal chlamydia diagnosis compared to those over the age of 25 or older. We also saw an association among patients who reported 3 or more partners in the previous 3 months. The strongest association we saw was for women who were contacts to chlamydia. So in terms of limitations, our findings may not be generalizable to all clinic attendees or to the general female population seeking sexual health services. While almost all screening encounters included urogenital NAT, lower proportions included rectal and or pharyngeal NAT. Women who did or did not receive rectal screening did not differ by race and ethnicity. However, those with rectal screening tended to be older compared to those not screened at the rectum. And sexual exposure is, of course, based on self-report. So there's a chance of misclassification in our analysis if patients, due to either social desirability bias or recall bias or for some other reason, did not accurately report engaging in anal or oral sex. In conclusion, we detected a substantial number of extragenital infections, which without appropriate screening would not be adequately treated, if at all. We saw that anal sex was not predictive of rectal chlamydia infection. Limiting testing to women reporting a history of anal sex or rectal symptoms could miss a significant number of infections, which has implications for chlamydia control programs. And so other patient factors should perhaps be considered for expanded screening, specifically in sexual health settings. And it's been postulated that some rectal infections may occur from contamination among patients who have genital infections, cross-contamination. And so continued research on transmission modes of rectal chlamydia is definitely needed. I'd like to acknowledge my collaborators on this work: Addie Crawley, Tarek Makati, Susan Blank, Susan Fallon, and Julie Schillinger. I have my contact information here. Please reach out with any questions, and thank you very much.
Trend in rate of PID diagnosis among commercial insurance women aged 15 to 44 years in the United States, 2009 to 2017. PID, an infection of upper female genital tract, is often caused by STI and may result in severe reproductive consequences such as infertility, ectopic pregnancy, and chronic pelvic pain. The objective of this study is to describe a trend of rate of PID among commercial insured women aged 15 to 44 years in the United States. The IBM market scan data was used in this study. The data is contributed by a larger employee managed care organization, hospital, EMR provider, Medicare, and Medicaid. The data is considered as one of the largest convenience sample in the US, which include over 245 million unique patients since 1995, which also include 40 million patients in 2012. The data can be used to conduct a longitudinal study. The study population is women aged 15 to 44 years with a commercial insurance. PID was identified by ICD-9 and ICD-10 diagnosis code. Patients were classified as having PID if they have one or more claims for PID during a given calendar year. Rate of PID for a given calendar year was defined as the number of women who have PID divided by the number of women who were partially or fully insured in the database in that year. Women with a PID service were hierarchically classified as inpatient, emergency, and outpatient based on all PID-related claims served by those venues in a given year. Simple regression model was used to estimate a statistical significance in trend. Result. This table shows the total number of commercial insured women aged 15 to 44 years from the 2009 to 2017. By looking the row in the total, we can see the number of women in first 6 years are pretty similar. The total number in the last 3 years are similar too. However, the number in the first 6 years will be much bigger than the number in the last 3 years. The total number of women by region also are very slightly from the year to year. This figure shows the PID rate per 100,000 women. The bar chart shows the PID rate among all women 15 to 44 years across the year. 3 lines indicate a 3 age group. From this chart, we can see women in age 25 to 34 have a highest PID rate among all of the 3 age group. This chart also shows there are 2 age groups who have a significant decrease in PID rate across the year. One will be among women aged 25 to 34. Another will be women aged 15 to 24. This chart shows the rate of PID per 100,000 women by a region. The 4 lines represent a 4 region. From this chart, we can see the women in the South have a highest PID rate among all 4 regions. This chart also shows there are 2 region groups who have a significant decrease in PID across the year. One will be the women in the South. Another will be women living in the Midwest. This chart shows the proportion of PID visitors that were outpatient among women aged 15 to 44 years with a PID by an age group. The yellow line indicates the women age 35 to 44. Red line indicates women 15 to 24 years. From this chart, we can see older women were more likely to go to the outpatient visit for PID compared to the younger women. This table shows the ICD-10 code distribution for women with PID. We use 2017 data to do this analysis. By looking the highlight, we can see about 47% of ICD were identified by a female PID unspecified. About 14% were identified by acute pyometritis and pelvic cellulitis. And there about 13% were identified by an inflammatory disease of uterine unspecified. Actually, we ran the similar analysis from the 2009 to 2017. The distribution will be similar across the year. Summary. Women aged 25 to 34 years have the highest PID rate among 3 age groups. Women in the South have a highest PID rate among 4 regions. Trend analysis shows that the PID rate statistically decrease among women aged 15 to 25 years and age 25 to 34 years. Also among women in the South and in the Middle West. Older women were more likely to have PID cared for in outpatient settings than the younger women. Most commonly used PID code will be unspecified PID, and the distribution were similar from the 2009 to 2017. Limitation. Market scan data are based on a large convenience sample. Because the sample is not random, it may contain bias or fail to generalize well to the other population. The data come mostly from a large employer. Medium or small firm may be underrepresented among commercial insured population. Administrative data can have error in diagnosis or care setting. Conclusion. The burden of PID in the United States declined 2009 to 2017, especially among women aged 15 to 34 years or those resident in South or Midwest. More research is needed to evaluate the reason for those observed trends. Understanding the driver of those observed trends in PID can help to inform future prevention opportunity. Women with a PID may be further assessed for treatment to the women themselves, treatment for women's sex partner who may have gonorrhea or chlamydia. STI counseling related condom use, have sex only with a partner who do not have any STI or limited number of sex partners. I want to thank you, Sarah Young at Emory University for data analysis. So Williams Pearson and Christian Crusell at CDC for their help on the inclusion of ICD-9 and ICD-10 code for PID definition and the crosswalk between ICD-9 and ICD-10 code. Thank you.
Hi, my name is Lisa Lindley. Thank you for coming to our session entitled HIV Sexual Risk Factors Among U.S. Women Who Engaged in Heterosexual Contact in the Past Year, Differences in Risk by Sexual Identity and Sexual Orientation Discordance. I'd like to acknowledge and thank my co-authors, Dr. Leila Fleming and Dr. Karen Frankenfeld, for their assistance on this project. As I'm sure most of you are aware, of the nearly 38,000 new HIV diagnoses reported in 2018, about 1 in 5 or 19% were reported among women. African American women and Hispanic Latino women were disproportionately impacted. Most of the new HIV diagnoses among women are attributed to heterosexual contact. In fact, overall, about 85–86% of all new diagnoses are due to heterosexual contact. And you can see here, this is true across race and ethnicity. While heterosexual contact is the category most likely to have resulted in HIV transmission among women, it doesn't fully characterize women who are at risk. Research has demonstrated that bisexual women and women who have sex with both men and women, especially in the past year, are significantly more likely to report an STD than heterosexual women and women who only had sex with men in the past year. When talking about sexual orientation, we usually consider it to have at least 3 dimensions or 3 different ways to measure it. There's sexual attraction, or what gender or sex is that folks are attracted to. There's sexual behavior, or who folks have sex with. And then there's sexual identity, or how we label our sexual orientation. Sexual orientation discordance is when these 3 different dimensions do not align. An example would be if a woman identifies as heterosexual, but reports having same-sex attractions or same-sex behavior. And we know that actually women who report sexual orientation discordance are more likely to have more sex partners in the past year, to report concurrent sex partners, and to have an STD. So we decided to conduct a secondary analysis of the National Survey of Family Growth 2011 through 2017 data to look at HIV sexual risks among women, in this case women aged 18 to 44, who had, quote, heterosexual partner in the past year, or heterosexual contact. So these women had to have had at least one male sex partner in the past year, and they had to have responded to the 8 different HIV sexual risk-related items listed in the survey, which you see here. Our final sample included over 8,200 women. We found in our sample that women who engaged in heterosexual contact in the past year were diverse in their sexual identity, attraction, and behavior. Overall, nearly 94% of women identified as heterosexual, about 6.5% identified as bisexual. When we looked at identity by attraction, we found some differences. We found that about 80% of women who identified as heterosexual said they were only attracted to men, while 13% of women who identified as heterosexual reported having same-sex attraction. And then you see again our 6.5% of bisexual women who reported attraction to men or women. Looking at identity by behavior in the past year, we found again that most women, 91% in this case, identified as heterosexual and said they only had male partners in the past year. However, a little over 2% of women identified as heterosexual and had both male and female sex partners in the past year, while 4.5% of women identified as bisexual and had only male partners, and 2% identified as bisexual and had both male and female sex partners in the past year. I'd like to point out, so about 9% of our sample basically identified as bisexual and or had both male and female sex partners in the past year. So keep them in mind for a little later. We looked at the differences, if any, that were reported among women based on their sexual identity, so comparing heterosexual to bisexual women in each of these 8 different HIV sexual risk factors. And basically what we found is that for every one of these 8 that we looked at from the survey, bisexual women were significantly more likely to report engaging in it or to have had it as a risk factor. The most commonly reported or most frequently reported sexual risk factors among women were having anal sex with a male partner in the past year, having a non-monogamous male partner in the past year, having 3 or more male sex partners in the past year, and being treated for an STD. There were 4 of these 8 risk factors that were reported less frequently than the previous 4. But again, bisexual women were significantly more likely than heterosexual women to report them. In particular, we're looking at having a bisexual male sex partner in the past year, having sex with a male injection drug user, exchanging money or drugs for sex with a male partner, or having sex with an HIV positive male partner in the past year. Overall, more than a third of the women in the sample reported having at least one HIV sexual risk factor in the past year. And you can see again, the bisexual women were far more likely to report having one risk factor, one or more risk factors. And again, bisexual women were significantly more likely than heterosexual women to report having two or more HIV sexual risk factors in the past year. About 29% of bisexual women compared to 11% of heterosexual women reported having two or more of these risk factors. Let me read this to make sure I say it correctly. A survey-weighted multivariable multinomial logistic regression analysis was used to evaluate associations with HIV sexual risk factors by sexual orientation discordance. And women were categorized as having 0, 1, or 2 or more HIV sexual risk factors in the past year. And as you can see, bisexual women and women who were heterosexually discordant were significantly more likely than heterosexually concordant women to have both one risk factor or two or more HIV sexual risk factors in the past year. So basically, we found that bisexual women and women who had sex with both male and female sex partners in the past year had disproportionate risk in our sample. Now, the full sample, we found about 9% of these women were represented as bisexual or having both male and female sex partners, while they actually represented more than a quarter of the women who reported having two or more HIV sexual risk factors in the past year. So some important considerations for the interpretation of these results. Our results cannot be generalized to all women. Although this was a nationally representative sample, it was a household survey. It's only an approximation of HIV sexual risk, and it's based on the gender binary. So all of the measures with regard to sexual orientation, all three dimensions, are based on that gender binary. So in conclusion, we found that a significant proportion of women at risk for HIV who would likely be categorized under the heterosexual contact transmission category are actually bisexual women and women who had sex with men and women in the past year. So one of the things that we think might be important to be considered is that to provide the best prevention services and treatment to all women is that an additional category, such as women who identify as bisexual or report male and female sex partners, be considered for inclusion in HIV and STD surveillance in the future. So thank you so much for coming to our session. If you have any questions, please feel free to contact me. There's my email address. I would love to discuss our work with you in more detail. Have a great day.